Hello and welcome to all of you joining us here this afternoon. My name is James Jopling and I'm the head of the British Heart Foundation in Scotland, and I'm speaking to you here from my home in Edinburgh. You're joining one of our regular live and ticking events. Each month we're delighted to bring you the latest news from BHF, pioneering research stories and personal accounts from people directly affected by heart and circulatory conditions. Today's session is focusing on heart attacks that are responsible for around 100,000 admissions to hospital in the UK each year. Now, first off, we want to get a sense of your current understanding of heart attacks. So a poll will shortly pop up on your screen that we'd like you to complete. So how would you rate your understanding of heart attack? Where 1 is 1 to 5, 1 is very little, and 5 is a lot. If you could complete that now, that would be fantastic. Thank you.
Okay, James, the results are in. The majority has gone for 3, that's at 43%. And then the next most popular is 4 at 26%. So everybody's sort of middle ranging.
Okay, super. That's really good to know. And one of the things we hope more than anything is that there's lots for you to learn from this session that you've joined us for this afternoon. So around the UK, every 5 minutes, someone is admitted to hospital due to a heart attack. And since the BHF was founded, understanding of how to diagnose, treat and prevent heart attacks has been one of the main focuses of our research. Currently, we're funding research projects addressing heart attacks that totals £37 million of money that many of you will have donated. NHS England has recently launched their new Help Us Help You campaign this month that some of you may have already seen. It's to increase understanding of heart attack symptoms after a poll showed that less than 50% of people said they would dial 999 if they or a loved one experienced lesser known symptoms of heart attacks. This new NHS advert will show a person experiencing some of the common early symptoms of a heart attack, sweating, uneasiness and chest tightness, and remind viewers to dial 999 if they experience symptoms like this. So look out for that in England, and we'll post a link to it in the chat box. Now, before the mid-1970s, nobody really understood what caused heart attacks. The only treatment was bed rest and pain relief medication. 7 in 10 people who suffered a heart attack in the 1960s didn't survive, and you'd be likely to suffer long-term health problems if you did. Now, in 1976, it was BHF professor Michael Davis that discovered almost all heart attacks are caused by blood clots in the heart's arteries. He also found that these clots form where the arteries are narrowed by buildup of fatty substances inside the blood vessels. Before this, it was thought that clots were the result of heart attacks, not the cause of them. And although it took several years for these discoveries to gain international support, now they are in every textbook on heart disease. Professor Davis's findings paved the way for the development of clot-busting medicines like statins that continue to save lives today. Now, thanks to all the life-saving research you've helped us fund over the last 60 years, today that survival rate is reversed, with 7 out of 10 heart attack patients able to go home to their families. And we're very fortunate today to start by talking to one such patient, and I'm delighted to be joined by Peet, who you may be familiar with as she's been featured previously on our Ticker Tapes podcast. Jean is going to talk about her experience of having a heart attack whilst putting on her walking boots one Sunday morning back in May 2020. She'll talk about everything that came after, as well as what it was like to recover during a global pandemic. I'm also delighted we'll be joined by BHF Chair of Cardiovascular Medicine at the University of Oxford, Professor Charalambos Antoniades. Research BHF has funded since 2011 has led Charalambos and his team to develop CaRi-Heart, an EU-approved artificial intelligence technology that can identify people at high risk of fatal heart attacks years before they strike. We'll then be finishing today's event with a Q&A session. So please do submit any questions you have via the Q&A function in the chat. But without further ado, I'm delighted to introduce Peet.
Thank you, James, and thank you to the BHF for inviting me to attend and talk about my experience of a heart attack. Let me give you a bit of background. In March 2020, my husband and I moved house. In March 9, let's start again, shall we? at the beginning of the March, we moved house, and within 2 weeks came lockdown, national lockdown. My whole life changed in that period of time. Everything we had planned for the house, everything, all our social life, like everything, it just locked down. And I found that really difficult because I had always led a hectic life and enjoyed life. So I started walking. And from that time, I was walking regularly. I had moved to this area 6 years ago, and it was absolutely new to me. So it was really great to explore the area. And this particular Sunday morning, I was putting on my walking boots, and I experienced a feeling, and it wasn't traumatic. And I have told many people, it just felt like an enormous bear hug. And for some reason, it just meant that I couldn't ignore it, but I didn't feel ill. I didn't have any other symptoms. And I do wonder today if it hadn't been for lockdown, whether I may have ignored it and tried to get over it. But as it was, I told my husband I was going to dial 111 and ask for some advice. Having dialed that number, of course, all I got was COVID information. So I thought I'd better actually step up and phone 999. My daughter works in the local hospital, and although I hadn't seen her for a couple of months and I had no idea of whether she was working, being a mum and still in control of my thoughts and being very controlled, I decided I would phone her first, and I would phone her home number. So if she answered it, I could tell her. And if she wasn't there, I could at least tell her husband and he could warn her. So I then phoned 999. I phoned her and spoke to her. And within about 8 minutes, having phoned the 999, I then had the paramedics and my daughter at the doorstep. The paramedics were brilliant. It locked down. It was so strange. They were all in covered plastic PPE, and my daughter arrived at the same time. They were calm, they were kind, they were reassuring and extremely professional. My daughter actually did say that I'd gone to extreme lengths in order to get a cuddle, having not seen her for ages, and also how pleased she was that I hadn't actually gone out walking, because otherwise I would have been in the field with the cows, and she would have been petrified of that. So they stabilized me. They took me down to the hospital, and I had to remain in the ambulance until the cath lab was ready. And once they were ready for me, they took me into the hospital. The corridors were really quiet. It was like the Mare Celeste. But once you got through the double doors and into the cath lab, it was, as my experience, a normal hive of activity, and everyone was absolutely amazing. They explained to me that I would need a stent put in, and the procedure went ahead. It went ahead with absolutely no problems, and they moved me up onto the cardiology ward, where I stayed for 3 days. It was peculiar because there was nobody there. I had no visitors, nobody at all. But it felt safe because you had doctors and nurses, and it felt as though you were secure. After 3 days, I was back home, and that's when the isolation set in. There were no visitors. I was virtually on my own, and the anxiety started to come through. And I also felt guilty. I felt guilty. I was angry with myself. What had I done to enable this to happen? And it was just a really, really dark and horrible time. And although I had worked for 25 years as a counsellor in the NHS, I still struggled with these feelings. And it was during a phone call to my GP regarding my medication that she suggested I looked on the BHF website, which I did. And it was at this point I found the ticker tapes and the podcasts, and it was about 3 ladies who'd all had heart attacks. And it was just such an honest story. They told their stories, and I really related to it. And they talked about anxiety, and they've talked about guilt, and they've talked about everything on this that you could imagine. And it was just done so naturally. It wasn't staged. It was real. And following the listening to these, I was able to come to terms a bit more with what had actually happened to me and not beat myself up about it. So I just wanted to, I was able then to talk to the cardiac nurse about how I started to recuperate, because there wasn't anything around at the time and I hadn't been given too much information. And so we started setting small goals, and I heard about the cardio rehab classes that had stopped, and I managed to find the guy that used to run them, and with my GP's permission I started doing some virtual classes. And within such a short space of time, because of this contact, I was back to walking 10,000 steps a day. I was feeling fit and healthy, and I was beginning to feel normal again, which was really important. And because of that, I needed to write to the BHF and thank them for what they had done for me. And here I am 2 years on. I'm still doing my classes. I'm doing Pilates. I work in a community cafe, helping out, and I'm a trustee of that charity. And I'm just about to rejoin the gym again because swimming pools are opening up, and I feel safe enough to go to those. So I'm really grateful to the NHS, and I'm truly grateful to the British Heart Foundation for the care, the support, and everything else they have given me. So thank you very much, and thank you for listening.
Thank you so much, Jean. I just wonder, reflecting on that time, is there anything you do differently or do again? Oh, you're on mute, Jean.
I would have perhaps phoned the 999 a bit quicker, but I have to say, we all think that these heart attacks are just so traumatic and everyone would know immediately that they'd had a heart attack. But I can honestly to this day say I wouldn't have known I was having one. That it wasn't that excruciating, it wasn't that defining, and because it was locked down, you didn't want to waste people's time.
No, I understand, and it's something we heard certainly early on in lockdown, and BHF and others did a lot to reassure and encourage people to contact the emergency services if they did experience symptoms very much like yours. But I can absolutely imagine at the time that sense of creating a burden for the NHS at a time when it was stretched more than any other was uppermost in your mind.
And somebody else said, a friend of mine's husband had just had a heart attack, and his was totally different. The whole world would have known about it. There were blue lights everywhere, and that just didn't happen with me. And I think maybe that's the message I want to get across more than anything.
And were you conscious then, and more so now, about how heart attacks might present differently for women to men?
No, I was not aware of that at all. I wasn't aware of it, and I wasn't aware of just how many women had heart attacks. I think that's the biggest lesson I've learned. I always, for some reason, assumed it was a man thing. Well, sadly, Jean, you can speak to the fact that it's more than that. Sorry?
You can speak to the fact that it's much more than that.
Yeah, it was just so much, that I honestly didn't think it would happen to somebody like me who didn't smoke. I exercise. I have a good diet. There is no history. That it would never have occurred to me that it was a heart attack.
Thank you, Jean. I'm sure there'll be questions that will pop up for you in the chat, so we'll come back to you after our 7th presenter. But thank you very much for now, Jean.
Thank you very much.
So I'm delighted now to hand over to our 2nd speaker, Professor Charalambos Antoniades. Charalambos, I don't know if you're able to share your screen with us just now.
Yes, super. Let me share my screen. Thank you, James.
No
it's
problem.
Exactly stories like the one you have just heard that motivates us in our research and gives us what we need to keep going, trying to develop new treatments, new diagnostics, in order, first of all, to prevent these stories from happening. We hope that at some point in the future, we will stop hearing these kind of stories. And also, when a heart attack happens, we need to make sure that we give the best of the treatments to our patients so that it becomes a much simpler problem than what it is today. We have done huge progress over the last decades, but there is a long way to go. So I will start by showing you a short video from the BHF about how heart attacks happen.
I don't think we can hear the sound, Charalambos.
Oh, there was no sound.
No.
Okay, I will make the sound myself then. I could hear it, but probably it was not coming through.
Thank you.
So the way heart attacks happen is when we have the development of these fatty deposits on the wall of the arteries. When these fatty deposits that are called atherosclerotic plaques break, then they cause the formation of a clot locally, and then that clot moves along the vessel, obstructs the flow of the vessel to a certain part of the heart, and that is how heart attack happens. That part of the heart essentially dies if we don't open it on time, and then it causes complications like heart failure, etc. So this is a schematic of exactly the same process that we have just discussed. So during the process of developing atherosclerotic plaques, you have these deposits, the lipid deposits in the vascular wall, and then at some point in the progression of this disease, we have obstruction of the flow inside the lumen of these arteries. When one of these plaques breaks, then you have exactly what I have shown you in the video, the formation of a clot that prevents blood from going through, and then anything beyond that point is at risk of dying. So the part of the heart that is fed by this vessel, by this artery, may then die. And this is really what happens with heart attacks. Now, it's important to understand that before a heart attack happens, we usually expect some symptoms. What are these symptoms? When we have an artery like this, where we have a plaque preventing the blood flow through it, through this narrowing of the artery, you have what we call angina. This is chest pain. It comes at the front of the chest, it radiates at the jaw, at the shoulder, or at the left arm. And that comes with exercise. When you try to walk uphill, you get a chest pain, you stop, it goes away, then you continue, it comes back again, and it's very reproducible. This is what we call angina. This has been the interpretation of how heart attacks happen for many, many decades, that these big plaques rupture. However, recent knowledge tells us that even the small plaques that do not give any symptoms of angina, they still break, and they still cause heart attacks, because when one of these small plaques breaks, a clot forms here, and then that obstructs the flow of the blood, and you have exactly the same problem as with the rupture of the big plaques. Now, what percentage of heart attacks happen because of small plaque rupture compared to big plaque rupture? If you ask even cardiologists, they will tell you that most of the heart attacks happen when big plaques rupture, but that's wrong. Research says that half of the heart attacks happen in this kind of arteries with very small narrowings. And this is the big problem here, because these are heart attacks that happen out of the blue, and the first symptom of coronary heart disease is the heart attack itself, is not any warning sign, is not angina. Now, that's why it's very important to understand why these small plaques rupture, not only why the big plaques rupture. And we know now from a huge volume of research that has been done around the world over the last 10 years that inflammation is the key. When an artery is inflamed, that artery will develop disease at some point. And when artery with disease, with plaques, is inflamed, then is this inflammation that will cause the plaque rupture and will cause a heart attack. So the big challenge now is to be able to detect this inflammation in the arteries, because this is what will cause a heart attack eventually. And if we are able to detect this inflammation, we need to be able to give treatments and to understand what treatments we need to give in order to prevent these heart attacks. And this is all about our research over the last 15 years. So in my group in Oxford, we have been focused for the last decade on understanding how the arteries, like the one you see here, supplying blood to the heart, communicate with what is around the arteries. And this is fat. This is fat tissue. It's this yellow material that we traditionally thought that this is there just to support the arteries. But we have found out that when you focus onto these arteries and the way the arteries communicate with the fat, the communication is much more complex. So when an artery is inflamed, like the one you see here, the inflamed artery secretes molecules, signals to the fat next to it. The fat cells there, they have the ability to sense these signals and they shrink, they become smaller. When they shrink, they give way to water. And then around an inflamed artery, you have less fatty content and more water, aqueous phase. This is this cartoon that seems so simple here. It's a decade of research in order to put together the different components of it. When you treat now vessels like this with statins or anti-inflammatory agents, you cool down the arteries, you reduce inflammation, and then the perivascular fat, as we call it, the fat tissue around the arteries, comes back to a more normal state. This sounds very complex science, basic science, but it actually has a meaning in terms of detecting the inflamed coronary arteries. Because if we are able to see these changes and measure these changes around the arteries, then we can detect inflammation in the arteries, and then we can predict heart attacks. This is because there is no way to see any changes inside the inflamed artery, but there might be an opportunity to see changes around the artery when the artery is inflamed, because the tissue around the artery is more prone to changes. Now, how can we see and measure inflammation in our heart arteries? So the only test, non-invasive test that we have at the moment that shows us the arteries, the coronary arteries supplying blood to the heart, is what we call CT heart scan. There are more than 200,000 CT heart scans happening every year in the UK at the moment. And 85% of them, they show minor or no disease, no plaques, and they are just archived as tests without any action. These are kind of black and white images that we get from this kind of test. Now, if I tell you that the artery you see on the left is a non-inflamed artery, and the artery you see on the right is a highly inflamed artery, you will ask me, how do I know that? Well, I know that because this is an artery that caused a heart attack a few years after this test. They look exactly the same, the inflamed or inflamed, based on the conventional analysis. So the question is, can we see this inflamed artery? Can we see inflammation in this artery, in this black and white image? The answer is we could. So we developed a method with funding from the BHF that uses artificial intelligence. It brings to the surface the hidden information that is not visible with the human eye, and then it turns it into information that you can see with your eyes. If I tell you now that the yellow color around an artery means that the artery is non-inflamed, because this is all fatty content, while the red color flags inflammation in the artery, then I'm sure that you will be able to recognize that this artery is inflamed. That is not the same, at least, compared to the one on the left. Now, the red color in these images means inflammation in the artery. The blue color is extremely dangerous. The blue color is what we call it's death. It's dead fat tissue around the arteries because of very severe inflammation. So it seems that this is a highly inflamed artery because not only it has red, but it has also some blue in it. Now, so if we can see these changes around the arteries and we can detect inflammation and measure this inflammation by using our artificial intelligence systems, then can we predict heart attacks? Indeed, this process gives us a reading that is called fat attenuation index. And then this reading is a measure of the degree of inflammation in the arteries. Can this predict heart attacks? We organized, again, with funding from the BHF Foundation, the Presubmitted study, which was a long-term study with 4,000 patients. 2,000 actually of these patients were included from Germany, 2,000 from Cleveland Clinic from US. This is because when you have a biomarker, a technology that is developed in one population, you want to test that it's applicable across the globe and it's not only specific to Oxford patients and Oxford equipment. And indeed, the patients in that study who had highly inflamed arteries based on this method, they had up to 9 times higher risk to die from a heart attack over a 10 years period after they had the test. And indeed, this is after we took into account any conventional means of stratifying the risk of these patients. So it seems that inflammation measured by this method is indeed able to provide a striking prognosis for future heart attacks. Now, how do we treat inflamed heart arteries? Let's say that we do find inflammation. What are we going to do with it? In the same study, in the Presubmitted study, we found that when an artery is inflamed, when a patient has inflamed coronary arteries, and that patient does not take any treatment, and specifically no treatment with statins or aspirin for the next decade after they had the test, they have up to 18 times higher risk to die from a heart attack over the next 8 years. Those patients with inflamed arteries that start treatment with statins and aspirin, and statins are very important because they have direct anti-inflammatory effects and they stabilize the plaques if they're inflamed. As long as we know who to treat with statins, we can stabilize these plaques, can cool them down. Now, these patients, they have absolutely no risk, no elevated risk for heart attacks. Now, why don't we treat everybody then with statins if statins are so effective? Well, that would be a challenge because statins, they have complications. Aspirin has complications. These are not simple drugs. So we have to be very clever in who we treat. And this kind of technologies will help us direct exactly the right treatment to the right patient at the right time. When we published this, there was a big press coverage. We even got the first page in one of the national newspapers because it's such a big thing. If you are able to predict the heart attacks, then you know where the next earthquake is coming, and then you know where to put the effort. Of course, having a technology that predicts heart attacks means nothing if it doesn't reach the patient. And this is a big problem that we had in academia, in universities. We create all these clever technologies that they stay as scientific papers. We present these technologies to each other. We congratulate each other, but they never reach the patient. And this is exactly what the BHF Translational Awards aim to do. This is a relatively new scheme in the BHF Foundation that brings innovation to the patient. It funds exactly this gap between universities and the NHS. And this is exactly what happened in this occasion. The clever science that was developed by using artificial intelligence in Oxford, it was funded to be delivered to the NHS. How did that happen? By creating a spin-out company that is called CaRi-Heart Diagnostics. And that company came from the University of Oxford as a result of a BHF Translational Award. This is the objective of this award, to create this kind of companies as vehicles to bring these technologies to the patient. And this is exactly how this technology works in practice. The patient sees a doctor within the NHS. The doctor suspects that this patient may have inflamed coronary arteries because they have some symptoms, non-typical symptoms, etc. They have a scan. They have a CT heart scan, and the result is then transferred by using internet to this cloud service that was created by the spin-out company. This is a cloud service that gets the scans, reads them by using our artificial intelligence system, and it quantifies the degree of inflammation in the arteries. Then it puts this information in context, and it gives an accurate prognosis of who is at high risk to have a heart attack over the next 8 to 10 years. It generates a report like the one you can see here, and then this report is sent back to the clinician who takes action and treats the patient appropriately. And what are these treatments that a doctor can give or can apply to the patient if increased inflammation is detected? Typical lifestyle changes, exercise, control blood pressure, the usual stuff that everybody have to do anyway. But the doctor can also prescribe statins if there was no intention to prescribe them anyway. This is a reason to do it. Increase the dose of statin if the patient is already taking statins. Take additional aspirin if the risk is extremely high, because aspirin will prevent the clot from forming if a plaque event happens. And also consider anti-inflammatory drugs. And there's a lot of research going on about new anti-inflammatory drugs that are being tested now in clinical trials. One of them, a very old drug, colchicine, that is used for arthritis, is actually very effective. It has been proven in clinical trials recently to be very effective in preventing heart attacks. So we know what to do as long as we know who to treat. Now, the journey from basic science to the NHS is typically very long. The discovery of the new biology, this complex cartoon that I have shown you at the beginning, the interaction between the fat and the space, the arteries and the space around the arteries, was discovered in 2011. In 2014, it took 3 years to develop the idea that we can see these changes using CT, these CT heart scans, and we can see inflammation. In 2017, it was when this concept was published. So that was the first time that this came to the public domain. And then the big trial, the CaRi-Heart trial that has proven that it can predict heart attacks, was published in 2018. Then, the same year, the company was founded, and the CaRi-Heart, which is the platform, the technology that I have presented to you, was developed, and the patents were granted in 2019. The first clearance from the American Food and Drugs Administration was given in 2020, the FDA. And the big landmark was in 2021, when this technology that is called CaRi-Heart received its CE mark as a medical device for clinical use in the UK and Europe. And this was the world's first prognostic medical device that uses images to predict heart attacks. The CaRi-Heart is now in the first NHS hospitals, is being tested in the NHS, and it's deployed in more than 20 hospitals in Europe and in Australia. And it's currently under evaluation by NICE in order to lead to widespread adoption by the NHS. We hope that in the near future, we will see national screening programs using this technology to have a true impact on healthcare in the UK and save lives. Now, who paid for all this research and development? It's the BHF. Essentially, it's you. The BHF Foundation funded these early stages of the research at every single step of this research. And this is probably one of the very few funding bodies in the UK that funds these early stages of development. When you have a clinical application, then there are other funding bodies that jump in to support it, like the NIHR, for example, National Institute of Health Research. And then, of course, you have the venture capitalists who come and invest onto the company. And this is money that come from abroad, not from the UK, into the UK, and they also support the economy of the country because this is part of the commercialization process of this kind of technologies. Then you have Innovate UK, the UK government that funds projects that are about to get into clinical healthcare. And then the NHS supports the very last step, which is essentially the deployment into the NHS hospitals. So it's a long process, but what you can see here is that the only funding body that covers this early development, without which nothing will happen, is the BHF. And this is why BHF support is very important in developing this kind of technologies that change lives. Now, this technology is applicable not only in predicting heart attacks, but it can predict in different modifications the risk for stroke. It can predict arrhythmias. It can predict problems with the aorta, like aneurysms and the progression of aneurysms. It can even predict diabetes. Different iteration of this can tell us which patient is going to develop diabetes. And all these are technologies that are being tested now within the NHS, supported by various NHS AI awards. Now, a big next step now is the testing, global testing of the technology across different populations in the world. We have the orphan study that includes 250,000 patients, 200,000 of these patients from the UK and 50,000 patients from around the world. And these are all being tested by using these technologies, linking this information with future outcomes. And this is how we retrain and recalibrate the technology in different populations around the globe. Now, before I close, I have a quiz for you, and that's a case. So this is a case that essentially has been presented in a group of colleagues, of cardiologists, but without giving them this piece of information that I'm giving you now. So this is how you expect to see a normal artery. So a normal artery, which is not inflamed, has this very nice yellow color around it. Okay, keep this in mind, and then you will answer the quiz. This is a patient, a male, 32 years old, with typical chest pain, treated with a statin. Okay, but the LDL, the cholesterol, was very low, so no problem there. Hypertensive, but taking tablets, the blood pressure was very well controlled, so no problem there either. Ex-smoker, stopped smoking, so that was good. A little bit overweight. He had some chest pain. Came to us. We did this test. All three arteries that supply blood to the heart, they have this nice white color inside them, black and white. Based on this, every cardiologist that we asked said that this is a normal scan by conventional means. And of course, the decision, our decision as a clinical care team, was to reassure the patient that he was on optimal treatment, 32 years old patient, so very low risk, and we suggest some lifestyle changes to lose some weight. Now, we have done now the analysis, the CaRi-Heart analysis, and we have these pictures. Based on what we have said about the colors around the arteries, what do you think we should do to this patient? Was our decision to reassure the patient that everything is fine and suggest only lifestyle changes correct?
Well, the results are coming in.
This is the question for you.
They were pretty evenly split, but now there is a clear favorite with no at 77%. So they're saying your decision was not correct.
That's not correct. Okay, I'll give a few more seconds. What's the final percentage? Because I can't see it from here.
So, oh, still Yeah, no, it's still 75% saying no and 24%, sorry, 76% saying no, 24% saying yes.
Excellent. So this is exactly how this technology reclassifies and changes the way we manage our patients. If you can see here, when we quantify this information with these nomograms, as we call them, you will see that this patient, the dot is a patient, each artery of the 3 arteries is beyond the 99th, 93rd percentile in the distribution. This is like the nomograms we have for babies to evaluate the dimensions of their head or their height, etc. It's exactly the same thing, because it helps you position the patient in the context of their peers. And the calculated prediction for a fatal heart attack in the next 8 years for this 32-year-old gentleman was 1 in 3. This is massive. If you have this kind of, if you have risk to die from a heart attack more than 1%, that's a red alarm for a young patient of 32 years old. This was 31%. This patient indeed died from a fatal heart attack 35 months after the scan, before he reached the age of 35. If we had this information back then we will be able to intensify the statin treatment, give aspirin to this patient, or even consider colchicine in today's practice. So we wouldn't reassure the patient and send the patient home. This is exactly what how this kind of technologies can change practice. Now, all these now are done by computers, and this is how we envisage the life of busy clinicians in the NHS in the coming years. This is the dream of every radiologist, maybe not of the cardiologists, but definitely of the radiologists. I will leave it here. I would like to thank, first of all, the BHF Foundation for organizing this webinar, but also for funding our research for more than a decade, and for supporting our research in Oxford and around the UK to prevent heart attacks and develop new treatments to treat patients who have the heart attacks.
Thank you so much, Charalambos. So much for us to take away there, both the dedication you've shown in your teams along the way, and the length of time it can take to make these kind of life-changing and developments. So thank you so much. I know we've got a stack of questions that have come through. So if it's okay with both of you, I'm just going to jump straight to some of the pre-submitted questions. And this might keep you on your toes, Charalambos. Firstly, for our professor, how long do stents last?
Yes, the stents, they don't have an expiry date. So
okay.
Stents, from the moment that a patient has a stent, if the patient takes their tablets, make sure that the blood pressure is well controlled, the cholesterol is low, exercise is systematic, and the patient stays fit, there is no expiring date for a stent. If we deviate, then there is a possibility the stent to be occluded, develop what we call in-stent restenosis, or even have a heart attack from a ruptured plaque inside the stent. So it's all about making sure that you take the right treatments.
Okay.
And then the stent does not have an expiry date.
Great. Fantastic. Next question again. Reflux, and on a couple of occasions it felt so bad I had to visit A&E. How can someone tell the difference between a bad attack of acid reflux and a heart attack?
Yeah, there are some very, very nice tips that one can keep in mind. So typically the chest pain that comes on exertion when you exercise, when you walk, is from the heart, is not from your reflex.
Okay. Typically,
the pain from the heart will go away when you rest. If it continues and it spreads to the shoulder, to the jaw, to the left arm, then you need to go to the doctor because it's possibly a heart attack.
I see.
The pain from reflux is more common in the night when people sleep, because the reflux is just because of gravity. The content of the stomach will come up, and then you have more symptoms in the night. However, if there is any doubt about the nature of the pain, go to your doctor, have an ECG, and your doctor will know if that is a heart attack or not.
Fantastic. Jean, a question for you. What do you think helped you most during your recovery?
Probably determination that I wanted to get fit again, and not accepting that this was it. So I think the support that I got, as I said, from the BHF and from the initial support from the NHS, but actually it's then down, you know, as we've been talking about, it is down to the patient, I think, to actually take on board what needs to happen with exercise. I've always exercised. I can't remember a time in my life when I didn't. And I've always eaten well, but it was to keep that going. And I think that was the most important thing, is to try and have a healthy lifestyle, but still live a life.
Fantastic.
That's so important. If you don't live a life, then you're not going to have a life. So, you know, there has to be some treats, there has to be things, but don't, you know, do everything in moderation.
Given the professor is nodding, I'll take that as good advice, Jean.
Thank you.
Absolutely.
One more for you before we go to some of the live questions, Professor. Why do people say if you have a stroke, it's a precursor for a heart attack? Is that the case?
Well, it's not always the case. These are two different things. However, there are some commonalities. A type of stroke happens when a plaque in the carotid arteries, in the arteries supplying blood to the brain, breaks, and then that plaque will cause a stroke because it will move north and will cause a stroke. That's exactly the same thing that happens with the arteries of the heart. When a plaque ruptures, it travels, causes a clot, and then you have a heart attack. So that's people who have plaques in their carotid arteries are likely to have plaques also in the coronary arteries. However, this is only a percentage of the strokes due to plaque rupture events in the carotid arteries. Most of the strokes, they happen as a result of an arrhythmia. It's called atrial fibrillation. When you have clots forming inside the heart, which are irrelevant to atherosclerosis, then they can go out from the big pipe that gives the blood out of the heart, which is called aorta. And then the clots can go either to the head or to the legs, you know, south. If it goes north, then you have a stroke. So this kind of stroke is not related with the risk of heart attacks. It's a different pathology. They have some common risk factors like hypertension, for example, high blood pressure, but they are not directly linked. So people who have that kind of stroke may have absolutely healthy coronary arteries and no risk for heart attack.
I see. Thank you very much. I'm going to now hand to my colleague Jana, who's been keeping an eye on the questions coming in through the live session. Jana, over to you.
Hello. Yes, we've had loads of questions through, so thank you to everyone who submitted them. So the first question, I'm going to go to you, Jean. Lynn has asked, where did you feel the bear hug that you described? Was it just in your chest, or was it all around your upper body?
It was all around. I've often, people have asked me this a lot of times, and my answer is I have teenage grandsons, and they'll sometimes come up behind you and give you a big hug from round the back and a big squeeze. And it was that feeling of a big hug and being squeezed. I think that's the most obvious way I can describe it. It wasn't in one place. I didn't get pain in my neck or my arms, but it was like a really strong bear hug where you say to them, oh, for goodness sake, come on, move away. And it was like that.
Thank you for sharing that, because I know it's so important. There could be so many different kinds of symptoms.
Absolutely.
Experience. So thank you. One for you, Charalambos. There's been quite a few questions about inflammation, actually, so I'm going to kind of combine a couple of questions. So what are the causes and symptoms of inflammation in the arteries, and can you treat it with medication?
Yes, so there are no symptoms of inflammation in the heart arteries. The symptom is the heart attack. Right. When it happens. There is no warning. This is why it has been mission impossible up until now to detect and measure this inflammation in the heart arteries. If you read the textbooks in cardiology, when they discuss about atherosclerosis, in the last chapter always, they say, maybe sometime in the future, we'll be able to measure inflammation in the heart arteries and predict heart attack. So this is what is happening now. We are at the last chapter of the textbooks that is becoming reality. Now, what causes inflammation? It's all the risk factors together is multifactorial. It's the high blood pressure, it's the high cholesterol, but it's also genetic sometimes. Sometimes it's the genes that increase inflammation. It could be air pollution, it could be alcohol, it could be anything. There's a long list of possible causes of inflammation that will lead eventually to heart attacks. And you are never sure which patient is resistant to these factors and which patient is not. Because with the same amount of exposure to risk factors, some people develop inflammation and some people don't. It's like smoking. Smoking causes inflammation. In the vast majority of people, there is a very small minority that will never have any problem with smoking, but that's a very, very, very small minority. So you cannot, we try to generalize as much as we can, but there are no absolute rules because it has to do with the vulnerability of the body to develop inflammation in response to this stimuli. How do we treat it? So statins is the #1 treatment, simple, cheap, relatively innocent, that we can give to these people and reduce inflammation. If people take statins and they still have high inflammation in their arteries, then we just increase the dose. If we increase to the maximum dose and there is still high inflammation, then we can consider potentially specific anti-inflammatory treatments. So there is a lot of discussion going on in the scientific community at the moment about anti-inflammatory drugs and whether these are effective or not. Large studies that have been published in the last couple of years show that simple anti-inflammatory drugs like colchicine, they reduce the risk for heart attacks. But this is a very active field of research. So the question of what do we do when we reach the ceiling of the statin treatment and we still have inflamed arteries, well, is still not answered. This is what we're trying to answer now.
Okay, thank you. And I suppose all those unknown factors are why it's so important to get this predictive AI technology off the start. So one question about that actually is it too early to have any evidence that this system is successful in reducing heart attacks? Or have you gathered any evidence on that yet?
Yeah, so we do have evidence, but these are not from randomized clinical trials. So the evidence we have is what I have shown you in one of the slides. So in the CRISP-T study, among those patients who had high inflammation, some of them started treatment with statins and some others didn't. The patients who started treatment with statins, they had extremely low risk for heart attacks, despite the fact that they had high inflammation at the time of the scan. Those people who didn't take any statins after the test, they had 18 times higher risk to have a fatal heart attack, to die from a heart attack over the next 8 years. 18 times. So this is the evidence that we have at the moment, that if you have inflammation and you don't take statins, then you have 18 times higher risk for a heart attack compared to those who do take the statin in the presence of inflammation. So this is the evidence we have now. Of course, we will need probably large-scale prospective randomized studies to look into this in more detail and quantify this more accurately. But this is ongoing research, which is validation within the NHS that is taking place at the moment.
Fabulous, thank you. And a question for you, Jean. How has your life changed since your heart attack?
To be honest, it hasn't. I would say that I'm as fit as I was before. I do as much exercise. As I say, I'm rejoining a gym. I walk the dog. I walk up hills. I was very, very lucky. I don't think I have any side effects or any repercussions from it. I often feel that I've put on a few pounds in weight and wonder if that's the medication, but so be it. Just get on with it. But no, I honestly, 2 years older, but none the wiser, I suppose.
I suppose that's quite a nice thing, actually. It hasn't like negative impacted your life. It's just the same.
No.
And you can carry on.
And I think I'm very lucky. I'm one of the very lucky ones, but I'm also my personality is also quite stubborn and quite determined.
Yeah, I can see that. And I think that's all the questions we have time for today. So I'll let you wrap things up, James.
Thank you, Jana. Thank you so much. And I know so many of you have asked questions we haven't got to, which I do, it's fantastic you've shown that interest, and visit the BHF website. There's so much information on there, which I know can help. I just want to thank all of you who've dialed in today and spending an hour of your late afternoon with us. I want to thank Charalambos for making the complex so accessible to so many of us. I want to thank Jean for making the importance of our research so very, very real. We hope you've enjoyed hearing from our speakers and how critical your support of the BHF is for the kind of work that Charalambos is doing to fund the most important science that we can. Now, just before we wrap up, we wanted to check in with you as to your understanding of heart attacks. So we have another poll question appearing on the screen. If you could just quickly fill that in for us. So how would you rate your understanding of heart attack now? 1 to 5, 1 being very little, 5 being a lot. If this has shifted negatively, that does reflect badly on Charalambos, and we'll
It's looking good so far.
Oh, you've done well.
So there's still a few more trickling in, but at the moment 50% have said that they've rated themselves as 5, so a lot, that's great. And 42% have said 4, so just the one below that, which is a massive increase from the majority being at 3. So
well, to both Jean and Charalambos, 5 before was 13%, so we've now gone up to 51%. So you can both attribute that to your friends and family and to your colleagues of what a good job you've done today. That's fantastic to see that this session has helped, and we're really pleased. So just to wrap up, a reminder that this event was recorded and will be available on our website from next week. And if you want to hear more from Jean, you can find her Ticker Tape podcast, which is dated May 2021, and Jean's story from a link on our website or wherever you get your podcast from. We'd encourage you to give us your feedback and suggestions by completing the survey that will be sent out to all of you who've attended an email. It'll help us shape future events and better meet your needs where we can. We hope also you'll be able to join us for the next live and ticking event on the topic of cardiac arrest and CPR. That's going to be at 4 o'clock on Wednesday, the 30th of March. Please tell your friends and family and share through your networks. And if you haven't signed up already, please do visit our website. The link will be posted in the chat box now so you can find out more details. And just to say, we couldn't do any of this work without the support of all of you on this call. We're delighted that Jean's with us here today. We're delighted that Charalambos has been able to evidence so brilliantly the importance of BHF funding at all of those stages in the work that he's been doing, and what a future it holds for us in terms of hopefully being able to better predict those at a greater risk of heart attacks. So thank you for joining us today. Thank you to our speakers again, and that's goodbye from all of us at BHF for now.